time out of your day to join us. So Dr. Robbins and I collaborate in Los Angeles together. I'm a pediatric speech and language pathologist, and she's a pediatric dentist. The little picture in the corner is just a corner of when we were playing one night after lots of learning on a really cool continuing education weekend. So we're going to think that, it's not just children that play, it's all of us. So today we're going to be talking about an area that's near and dear to our hearts, and kind of looking at airways and oral functions from a different perspective, and how we can help families, if you're therapists, if you're dentists or doctors, how we can kind of move them along. Can I get a raise of hands as to how many of you are therapists in here? Maybe
Orofacial myofunctional.
Oh, sure, orofacial myofunctional therapists, raise your hand. Hands, thank you. How about speech pathologists? OTs or PTs? Do we have any dentists? Raise them high, come on! Oh, look at those progressive dentists, awesome. These are the people you want to go to? All right, so today we're gonna look at risk factors and barriers for children's lack of play in today's society. And we're going to describe some of the benefits of gross motor, sensory motor, fine motor, and other foundations for play that are important for children. We're going to hopefully have time to take questions at the end, but we're going to hold off on them for now. For those of you that are therapists, has anybody ever just said to you, oh, they just played with my child? You're all familiar with that, right? That's happened to me too. Okay. So if we look in the literature, there's about over 20 words to describe play. It can be outdoor play, purposeful play, functional play, active, imaginary, creative, unstructured. So obviously play is more than just play. We know it's been around for as long as humans have been. This is one of my favorite species, and I had the pleasure of watching them play in Canada last year, so orcas play. We know that the fetus play in the womb, so for humans, that's where play begins. It's been referenced by philosophers back to the 1600s. And Freud said life is an interweaving of work, love, and play. And if you look at Parton and Montessori and Steiner, they were some of our earliest researchers in the areas of play. For those of you that are speech pathologists, you know the connections to cognitive development that we learn about in school in terms of Vygotsky's work and Erickson and Piaget. Interestingly, in 1955, it was around the Mickey Mouse Club. Mattel did a commercial that was outside of the Christmas season, and it was for something called the Thunderbird, which was a gun. And that is when play shifted to being more object-driven. Okay? Just kind of a fun fact. And if you look at the past 20 years, we can all kind of, I think, agree that kids have to have play scheduled. It's not like when we grew up and we just went outside after school till dinner time and played. So this is one of my favorite quotes. Play is often talked about as if it were a leap from serious learning, but for children, play is serious learning. Play is really the work of childhood, and I think we all know Fred Rogers. So let's think about, or maybe consider, what's the picture of play today? We were looking at some of the media devices. I know if any of you were in Dr. Mercola's lecture yesterday, you heard a lot about cell phones. So consider that 39% of children today have smartphones, 22% have tablets and televisions in their room, and 17% have laptops. And 7.5 hours a day are spent on screens for kids today. Some of that is from the screens they're exposed to in school, some of that is after school. Kaiser did a study, and they found that in 2-year-olds, 68% regularly use tablets, 59% have a smartphone, which is really an access to a smartphone, and 44% have a video game console. But what's even more shocking is that in the US, the average baby starts watching TV at 5 months of age. And in the last few months, I had someone come to me who said, hey, Nicole, is 5 hours a day of TV for a child okay? And I kind of, after I got over the shock, and I was trying to be polite, said, well, how old is this child? And she said 5 months old.
Oh.
All right, so we can all be shocked over that, but that's kind of the reality of what we're looking at. physical activity. We only have 1 in 3 children that are physically active every day. Nationwide, when we look at our kids with special needs and disabilities, they're getting less physical activity. Okay, so guys, think of sedentary behavior and what this is going to be doing for the airway in the body. Children today are spending 50% less time than what we've spent or their parents spent in play. All right, and this is kind of profound. Prisoners in maximum security prisons in the US get at least 2 hours, right, of outdoor times a day, and half of children worldwide spend less than an hour outside every day. And look at this.
I just make one comment about the picture. You see this kid with mud all over his face, kind of what it was like when I was a child growing up and playing. And then we look at today of the amount of allergies and symptoms that children have because they're not playing in the mud anymore.
And that's the little boy that goes up to a book and thinks he can swipe it.
Yeah.
Right? So another challenge when we look at play is what's going on in terms of children's bodies and the sedentary behavior and obesity. Okay, so from the 70s to 2008, we've seen in 2 to 5-year-old children, obesity has doubled from 5 to 10%. In kids from 6 to 11, obesity has quadrupled from 4 to 20%. And in kids 12 to 18 years old, obesity has tripled from 6 to 18%. Okay, and whatever we do in our practicing lives, this information is important. So all of these things kind of lead to children that are living what I call in a limbic world. Okay, they're living in the limbic systems, the lower part of the downstairs brain. They're living with more airway function disorders. The 25% of the emotions children today feel in classrooms are anxiety. I know in my own caseload, upwards of 50% of the kids in my practice have a diagnosis of anxiety, and yes, I have lots of airway kids. There's kids dealing with toxic stress. We've got special needs kids, those with sensory processing disorders, retained primitive reflexes can put us in our limbic systems, internet addiction disorder and digital dementia, which Dr. Robbins will go into more. So they're up against a lot. And if we look at some of the headlines, these are powerful. The decline of play and the rise in children's mental disorders, 2010. Okay, the decline of play in preschoolers and the rise in sensory issues. How are we going to get to their mouths when they're just struggling to have appropriate adaptive responses in their environment to sensory stimuli? How America killed play and what we can do to bring it back.
Sure.
All right, kids under 9 spend more than 2 hours per day on screens. And whatever happened to go outside and play? Do you think we're really getting the message in 2019? Anybody? Now, the answer is no. Is anyone aware of what happened in 2018 with pediatricians and the American Academy of Pediatrics? Okay, well, this is now where we are. The American Academy of Pediatrics issued a statement. They published their article in 2018 in Pediatrics, really asking pediatricians to step up and play a key part in getting children to play, and at all well child care visits up to the age of 2, writing now a prescription for play. Which Dr. Robbins and I, after going through all the research, feel like, hey, they should be writing them throughout childhood, not just up till 2, right? Because we all play as adults. But what are we going to do next? Are they going to need to write prescriptions to breathe, prescriptions to eat? And in that statement, they said they are going to encourage parents from the time children are really young and infants to interact and respond to nonverbal behaviors. If you're a speech pathologist in here, you've been trained, you do a lot of that, right? And to advocate for the protection of children's unstructured playtime because of its many benefits to motor development. And the lifelong prevention of things like obesity, hypertension, and type 2 diabetes. So why should a pediatric SLP and a pediatric dentist, why should we all care about play, right? I think you guys are putting the pieces together and you're going to answer this. But play is brain building. And when we look at the airway and oral functions, all these things play a role. From the sensory part to the motor to oral functions. The autonomic nervous system is huge, sleep. There's a social component. Michelle Price-Emmanuel did a beautiful job yesterday talking about reciprocity and attunement. And who, when we are looking at play and changing the brain, we've talked a lot about neuroplasticity, and thankfully for Dr. Marion Diamond, she's the one that did the research on the rats, the neuroscientist who looked to see what happens when you put rats in enriched environments. This is the woman who we know about neuroplasticity because of her. When comparing rats in enriched environments to boring environments, she found that the enriched environments resulted in thicker cerebral cortices, and that the smarter rats got through mazes more quickly. Okay, other researchers looking into rats, Gordon et al. Found that increased levels of brain-derived neurotrophic factor were increased after rough and tumble play, and that BDNF is essential for maintenance of brain cells. And in our airway kids, we're struggling that they're not getting enough oxygen to promote the brain cell growth and development and function. The ability to explore also increases BDNF. Dendritic length, complexity, and spine density of the medial prefrontal cortex are refined by play. And in some of the lectures I do, I talk about the prefrontal cortex because in a lot of our airway kids, they're in their limbic systems, right? They're in that fight, flight, or freeze mode, not getting to the PFC, which is where we have executive function, where we self-regulate, where we problem solve, where we attend, where we come up with new ideas. That's how kids progress through our therapy. They have to be on board with us. We want them in that part of their brain. Okay, we know that play stimulates the production of BDNF in the RNA and the amygdala, in the dorsolateral frontal cortex, the hippocampus, and the pons. And in terms of the pons, it's the facial, trigeminal, and abducens, in terms of cranial nerves that are going to be coming out of those pons. And those three cranial nerves we want on board. So what are some of the benefits of play? To the sensory system, it allows children exposure to different textures, which we know if we want them to accept different textures in their mouth for chewing, for swallowing, we've got to start with those experiences in other parts of their body. Okay, your kids that can't tolerate things on their hands are a red flag. It's our interaction with the world. It promotes overall body awareness. If we don't have body awareness out here, how do we have it in the mouth? It aids memory for new learning because anytime you add more senses to learning, you increase the likelihood of that person transferring things to long-term memory. We know that it promotes cranial nerve function. You have to sense before you can motor. And in terms of motor benefits, there's benefits to static and dynamic posture. Okay, we all look at that in our kids, right? We're looking to see their gait when they walk, how they are sitting in a more static position to look at the airway. It allows them to practice large and small muscle use. It's weight bearing, which is promoting good bone growth. It encourages respiration and expands their experiences. Socially, it buffers against stress. It promotes collaboration. I think we can all relate to this, right? How many of you feel better collaborating with peers, having friendships? There's research now showing people are living longer who have more enriched social experiences and networks. It develops empathy and shared attunement. These are important things. Okay, and emotionally, play can help kids to self-regulate. How many of your airway kids struggle to self-regulate? You're peeling them off the ceilings, right? It promotes autonomy and resilience and grit. If you're interested in grit, Duckworth out of Stanford has done a lot of research on this, and it's a great topic. Play has benefits to sleep. It reduces sleep latency. It helps kids get more restorative sleep, which I think we're all after. And in terms of physical growth, it's going to help them, when they're sleeping better, to get more of that human growth hormone. And it's going to help develop the craniofacial respiratory complex. Cognitively speaking, it enhances problem solving. There's lots of problem solving that goes on in play, generating novel ideas, executive function skills. And a lot of our kids struggle in this area. It improves learning and academics. Okay, for the airway, it's going to improve lung volume. It's going to strengthen the musculoskeletal system for optimal posture. And it's going to reduce BMI and the potential for comorbid conditions. As a speech pathologist, I'm all about oral functions. It helps normalize the oral sensory system. Again, it's giving kids that exposure to these different sensory experiences. It provides opportunities for speech acquisition, okay, another way we use our tongue. Reduces parafunctional habits, and it promotes chewing. And chewing we know is important for a myriad of reasons. So we kind of want to play through the airway. I'm not going to spend too much time on this slide. I think all of you probably know the benefits of breathing around the clock, and particularly sleep disordered breathing. We know it contributes to cardiovascular health, the regulation of blood pressure. It suppresses tumor growth. It offers a healthy or promotes a healthy immune system. And the glial cells clear toxins from the brain, right? When we sleep and that lymphatic system opens up and flushes everything out through the cerebral spinal fluid to the liver. Dental occlusion and the health of the TMJ. Okay, and we have development and function. All those areas of function are impacted. And at the beginning of this year, Applebaum and colleagues found that sleep serves to normalize the level of DNA damage in each single neuron. Okay, so if you were in Nicole's talk yesterday, again, maybe we can do something with sleep here to counteract the damage we're doing. So as a therapist that functions or focuses on functions, I like to think of all these mouth breathing, sleep disordered breathing, OSA as airway function disorders. Okay, they arise from compromised airway function at any level of the airway over the course of a 24-hour period. They diminish our child's capacity to achieve optimization of a range of functions, not just oral functions, but all the other things we went through, including self-regulation, cognition, socialization. They alter craniofacial growth and development. You guys know this. They dysregulate the autonomic nervous system, which is really important. Again, we've got people in their fight or flight mode. And they can occur in the presence of habituated behaviors and at any point during a lifespan. Sleep disordered breathing we know is an umbrella term, and I'm not going to spend much time on this. You guys know this, right? If you don't, give me a subtle clue that you want me to stay here. Okay. Prevalence-wise, I just want to say on OSA, usually we think of it being up to 4%. There was an Italian study that I found that put it up to 13%, and I think most people agree that we just not really begun to identify it. Kevin Boyd recently in Vancouver said we've got 2 million kids in the US with OSA, and quite frankly, that's 2 million kids way too many, and that's probably not even where we are. But let's just say we know it's associated with morbidity in children, so these are all things we want to address. Some of the research on impact of function, I'll get into the autonomic dysregulation on the next slide. Executive function skills matter because metacognitive skills are the #1 predictors of academic success. Okay. Academically, there was a meta-analysis that they did. There were 16 studies out of 12 different countries that found that all core areas in academics were impacted by sleep disordered breathing. So that's reading comprehension, reading, spelling, math, and science. Socially, we know that kids with sleep disordered breathing tend to be more aggressive. They are twice as likely to exhibit bullying behaviors. And in the autism spectrum disorder, they found that when we deal with sleep issues, a lot of their core behaviors start to go away. And I think that in any condition that a child has, whether it's sensory processing disorder or autism spectrum, those things all get exacerbated, just like we all don't function as well when we don't sleep. Behaviorally, these kids are at a higher risk of depression, and now there's studies coming out showing an increased risk of suicidal ideation in these kids. Okay, from a speech perspective, phonology and language, okay, language in children with obstructive sleep apnea they tend to struggle more with their receptive vocabulary development. And there's so much research in the speech, swallowing, or evolving research and chewing that is impacted. Okay, so this is kind of the plight of our airway kids. If you look at the autonomic nervous system, there's 2 branches. Okay, you want to consider when you have that repetitive hypoxia, what's going on to the sympathetic nervous system, the fight or flight mode, versus the parasympathetics, which is, our rest and digest. And they looked at heart rate variability in kids with OSA and pretty much found there was this overflow of the sympathetic nervous system and sympathetic tone in the daytime, and that the parasympathetics weren't really kicking in these kids. This is why I think we see non-nutritive chewing, because I think kids intuitively know that if they can chew on their clothes and their pens and whatever's around their neck during the day, they can put themselves into their parasympathetics, because we can never get them into our treatments, or we do, but it's a much harder thing to do when they're in their limbic system and not their prefrontal cortex. And we know they don't learn as well. Have any of you seen this quote from Karen Purvis? She really looked at mitigating effects of trauma in childhood through trust-based relational interventions. I think she's since passed away. But I think there's a lot to be said for this, and we forget about it in the whole drill and kill of therapies. Okay, so in kind of supporting what she's saying, Amat and Wang did research and found that when children play, their cortisol levels don't increase. Okay, we don't want their cortisol levels to be increased. We know that neurotransmitters that are good for the brain and the body are increased in play. So dopamine, for instance, which aids recall for new learning. You get the body moving, you release dopamine, you're more likely to impact memory. Kids come in, we want them to remember to carry over new skills. We want them to remember what they're going home to practice. Serotonin, again, just feelings of well-being and happiness. Socially, we talked about this earlier, there's social connections and support from another person that help children buffer against stress, since we know a lot of them are living in this limbic world, especially not getting enough play, having sedentary behaviors. And play lets kids, have a safe space to make mistakes, right? Because how many of you have perfectionists on your caseloads, right? And then, or perfectionists that are your children. I have one in my house. And the kids are willing to try new things through play. So Dr. Robbins and I take a play perspective within a developmental systems model, which is really airway-centered. It is neurointegrative, whole body, strength-based, and it's relational. Because we know that children are neurologically, physiologically, and sociologically wired to play.
Okay, so what I wanted to get across, and Nicole to get across about this slide, is what are the risks of staying indoors to our airway function? So indoors with our sedentary lifestyle, we have issues of obesity, the diet with our processed foods that we're eating, it affects our craniofacial respiratory growth, our forward head posture, our static and dynamic head posture, and also the lymphatic and glymphatic drainage, which may lead to airway function disorders, which can lead to abnormal breathing 24/7, mouth breathing, primary snoring, upper airway resistance syndrome, and then obstructive sleep apnea, which then in turn can lead to our oral dysfunction, which is our oral sensory issues or inefficient or inability to chew well, we can't swallow properly, and our articulation errors. You can't hear me? Talk. Make sure you're on. Like I'm chugging.
Then why would you think
Like this.
Yeah.
Okay. So now we're going to talk about the obesity, and here's a study by Mayport which showed that when respiratory function is affected by lung volume, and through the mechanical changes, we make cytokines, or there's an inflammatory response that occurs. And when the respiratory muscles are not working and there's a lot of fat distribution, reduction in the strength and resistance gives rise to inspiratory overload, which then affects our oxygen consumption. So what happens is we have adipose tissue that lies on the sides of the nasopharyngeal airway, and then it affects the volume of the tissue and its presence of how it affects the obstructive sleep apnea. So what we wanted to say is that in the early stages of obstructive sleep apnea, these fat pads seem to play a really important role in development of overweight people, overweight children. All right, so when we talk about our diet and processed food, there was a study that was done by Deter et al., and it was showing that mothers who were working, there was a high association between children's body mass index and obesity, especially in children of socioeconomic
It's the socioeconomic status.
Okay. And then those children who were of working mothers consumed more unhealthy foods and less healthy foods.
And sorry, moms, they did not look at that, so it's all on us.
Isn't that interesting?
And so a child that spends more time being sedentary is more likely to eat processed, unhealthy foods. And what I want you guys to consider is, how is food prepared today? And do we even prepare food today? We have so many foods that are already pre-made. We have kids that are eating like pockets of food that are all mashed up and soft, and they're not chewing. So to really think about where these foods are coming from. So I think this is like such an amazing Halloween costume. So if any of you guys don't know what to do for Halloween, that's perfect. Okay, so Michelle Manuel brought this up yesterday about the craniofacial respiratory complex, and according to Boyd and Lieberman, they talked about how the soft diets, and this is a quote actually from Howie and Michael Gelb's book, how soft diets eliminate the natural need for chewing, and this begins to change the shape of our faces, narrowing our jaws and restricting our airways. And the first person really to bring this up was Weston Price. Have you all heard of Weston Price? Okay, so restrictions of the craniofacial respiratory complex, but I actually like to include cervical because of the posture. So I really would like it more as craniofacial respiratory cervical complex, so that you can include the whole body. Okay? So these are just structural signs that you may see, and then the functional signs. And then our behaviors such as neurocognitive, academic, social, and emotional.
And the list, as you all know, isn't limited just to those things. These are just some examples.
Just some examples. All right, so everybody knows who this famous guy is here, right?
Yeah.
Well, Michelle Manuel yesterday did such an amazing job talking about how mirror neurons work, right? So here's a perfect example. Open mouth, and his son, open mouth. So it's really important how parents and caretakers need to interact and play with their kids. Now this is a study that was done by Hume, and it was showing the different patterns of facial development of sleep disorder breathing. And they took 600 orthodontic patients, and what they showed is that 16% had a long face form, which is shown so beautifully here. We have 86% with a convex profile, and over 50% of these patients had open mouth postures during the day. So if they have open mouth postures during the day, what do you think they're going to have at night? And this is from Dr. Mew. I believe most of you have probably seen it. Thank you. Okay. So I do want to mention that the x-rays that are going to be shown are actually the x-rays of the patient of the case study that we're going to be sharing. So I want you to just make note of what you're seeing so that when we present the case that you have an idea of what's. Okay, so the anatomic determinants of sleep disorder breathing, Dempsey did a study, and what it showed is that a short maxilla leads to a smaller airway. And it also showed that a narrow maxilla puts the nasopharynx at risk for collapse with loss of muscle tone. Okay?
technologically challenged.
Then we're going to talk, okay, so Airway volume, Heikin et al. What they were showing was basically where the smallest space behind the tongue is the best predictor of the nasopharyngeal airway volume. So I want you to see, so this is a CBCT, so this is a lateral section of it, and then we're taking this into a more horizontal coronal section, and this is the volume that's being measured. But what I also want you to take note is there are a lot of other things that you can see on the CBCT that many of you who may get reports it is not noted on. So if you look to the picture on the far right, when you look at it, you can see there's a rotation. Okay? So you're looking, there's a rotation or a twisting like this. Okay? Now when you come down into the cervical spine, you can also see that there is a twist. So if you were to make an educated guess, what do you think her bite is going to look like? If there's a twist in the neck and in the mouth there, any guesses?
You have a crossbite.
Exactly.
Awesome.
Okay.
Winner, chicken dinner.
Yeah, I wish I had a prize for you. Exactly. So even if you take a look at this and you want to start thinking beyond the teeth and looking at the whole body.
And could I make a note of that too? Neurologically, I just got an email the day before yesterday on this. Why is one side of the tongue working and the other side isn't? So you're going to see a disparity between the tongue action. So one side will be stronger, one side will be weaker.
Barbara, you are just so amazing because we can't wait to show you what the tongue looks like.
Do you want to come talk with us?
Yeah, come on up. You can come and Okay, so here's about poor posture and how it impacts our health. And we know through Wolff's Law that bone in a healthy person will adapt to loads under which it is placed. Now, so therefore, we can assume that abnormal postural stress and current loads will alter bone development. There was a research article that was just published by Berger, and it talked about osteoblasts and osteoclasts, that if you're in sympathetic drive, you're going to have bone loss, osteoclasts working. If you're in parasympathetics, you're going to have osteoblasts and bone formation. All right? Does that make sense? Mm-hmm. There was another study that showed that we're now seeing disc degeneration in children, which we weren't seeing before. All right, so this was a study that almost 9% of children who were 10 years old had disc degeneration with the developing spine. And because of these lack of inactivity, we're seeing a lot more osteoporosis and arthritis. And this was from the National Institute of Osteoporosis and Related Bone Disease Resource Center. Also with poor posture, it affects our mental health and also our lung function. So if we look over to the picture to your right, you can see where when there's good posture, you can see that there's normal chest shape and expansion, the heart's not compressed, and you will have maximum lung volume. As the head moves forward and we move into a more forward head posture, it's going to compress the chest, it's going to compromise the heart, and you're going to have less lung volume or less ability to be able to breathe. And now, when you're moving into a very forward head posture, it's really affecting, not only is it affecting the chest and the heart, but it's also affecting the back and the spine. So you can start getting some nerve issues and back and neck pain. Okay, so I'm sure many of you have seen this picture before. But what I wanted to emphasize is that when you just look at that picture, it's like, okay, 60 pounds, no big deal. But I want you to look at the picture on the left. That's a 60-pound child on someone's neck. That is what a child is doing when they're on their gadgets, on their cell phones, on their computers. Just want you to think about that. I just wanted to give that impact so that you can remember, like, that's a lot of weight on a young child. Okay. So, a neuroscientist, Spitzer, in 2012, came up with digital dementia. And I'm just going to read the definition of his definition, but the overuse of technology and excessive slouch sitting postures related to the breakdown of neurocognitive functions leading to signs and symptoms of dementia. Okay, so we're going to have short-term memory pathways are going to deteriorate from underuse if we overuse technology. Now look at this child on the iPad. How many of you in your practice, when they have their iPads, iPhones, computers with them, look like that? Mm-hmm. So too much technology, Dr. Nicole said it so beautifully, it can increase symptoms of ADHD, ASD, developmental delay, anxiety, learning disorders, all of these things. There's also mental health issues that it can affect, where it reduces the gray matter in the hippocampus, which is part of the related to spatial cognition, such as schizophrenia, post-traumatic stress disorder, depression, and dementia. Okay, so this is where it all begins. Look at the baby in the jumper. Look at the new sitting chair that they can put the iPad up. The only thing I'd say, at least he has good posture with it, right? But all of this leads is going to lead to the couch potato with the junk food.
That's Hila's Halloween costume.
There's no way I can eat those chips. Okay, so in 1995, Dr. Goldberg basically came up with internet addiction disorder. And basically, it's the same kind of addiction that someone has to drugs, such as cocaine, opiates, and methamphetamines. How many in your practice, when a kid is on their iPhone or on the iPad and it's ready for their appointment and they have a meltdown because that gadget is being taken away? Right? It's this. Here's the science to show it. Okay, so blue light and cortisol. We know that this technology emits blue light. And it also shows that the blue light increases our cortisol. If we have increased cortisol levels, it's going to shrink our hippocampus, which is associated with our memory and our recall. And it also disrupts the normal circadian rhythm. So children should be dreaming and not streaming. Okay? They're not sleeping. Yeah.
No, but keep going. I just want to make a comment on this. One of the important things about blue light is blue light at the right time. Blue light is really important when they wake up in the morning. Shade should be up, curtains should be open, they should get exposure to light. The whole thing about blue light, cortisol, and suppressing our melatonin is you're getting blue light at the wrong time. And our biology hasn't changed, our behaviors have, and it's going to take eons to change our biology, so we're going to need to change it.
Thank you, Nancy. That's very well said.
So Nancy is a world leader in sleep. She's a sleep ambassador, and she talks all over the world about it.
And she has the best book for kids called My Daddy Snores. Okay, you can do lots of play activities around that book.
Here it is. And there's a big giant revision and we're going to feed it off.
And Dr. Michael Yell wrote the forward the essay.
So the consensus is that when we have forward head posture, that is the major change that we see in mouth breathers. And so when we take our airway function disorders and our forward head posture and our internet addiction disorders and our eye postures, and we funnel them through, we're going to get a functional deficit. So in terms of our static and dynamic posture, what I want you guys to think about is our posture provides us with a stable base for our walking, our locomotion, how we use our arms and our legs, how our facial actions. And then we want you to look at and consider that poor posture can impact the respiratory function during sleep. So poor posture during the day, and I went over that slide that shows about the compression of the lungs and the heart. It's happening during the day, it's going to be happening at night. Okay, so incorrect posture, which leads to inactivity, back pain issues, and then sleep issues.
Okay, so Eric Jensen, if you don't know about him, is an educational neuroscientist and does lots of research on the brain. And he just found too much chair time leads to postural stress, poor circulation, and breathing. Okay? Okay, now I'm confused. I'll go back to this. Okay. Sorry, guys. All right, so we look at our airway kids, and a lot of them with enlarged lymphatic tissues. We know there's something going on with their lymphatic systems, don't we? And that is a system that's a very complex network in the body. It circulates important fluids to protect against infection. It includes the lymph nodes, the thymus, the tonsils, the adenoids. And we even have lymphatic drainage patterns in the tongue and the soft palate. There's a study by Pan et al. Okay? And movement of the lymph, that happens through rebounding activities, exercising, stretching, breathing. Okay, these are things we can do in play. Kids that are playing are moving their lymph. Imagine if we saw, or we didn't see, enlarged tonsils and adenoids, what that would do for all of us working with these kids. So, I think a lot of you know the Nettergaard study on the lymphatic system. It's a functional waste pathway for the central nervous system. It clears the brain of toxins while people sleep. That's why sleep is one of the reasons it's so important. And we know that deep, non-REM stage sleep is essential for optimal function of the lymphatic system. Unfortunately, these researchers produce so much that they themselves don't sleep a lot. I really like this Sleepidemic. This is out of Canada. They basically came up with a report card looking at giving a grade for sleep for children in Canada and starting to issue the world's first guidelines for what a healthy 24-hour period looks like in kids. And in their 24-hour movement guidelines, they were showing the interrelationship between physical movement, sleep, and sedentary behaviors, which we've been talking about. So the benefits of outdoor play are exponential, all right? Because if you look at air quality indoors, Tremblay and colleagues found it's often worse than the outdoor air. It increases exposure to allergens like dust, mold, pet dander, infectious diseases, and potentially leading to chronic conditions. Okay, vitamin D is crucial for sleep. It's also essential for bone growth, for the craniofacial respiratory complex. And let's face it, folks, we do not get D3 out of a light bulb. So some of the benefits of outdoor play, again, Tremblay and colleagues, finding that, look, you get kids outside, they move more, they sit less, they play longer. And all of these behaviors are associated with improved cholesterol levels, blood pressure, body composition, bone density, cardiorespiratory and musculoskeletal fitness, and aspects of mental, social, and environmental health. Okay, in the US, we have guidelines for physical activities for kids. For 6 to 17-year-old children, it's 60 minutes a day, at least 3 days a week. And we're looking for aerobic activity. That could be biking, soccer, swimming, muscle strengthening activities, bone strengthening activities like running, jumping, skipping, Okay, think of our kids that don't have body awareness, that have protruded scapula. What can you do? Climb up the play structure, climb up a climbing wall, right? Give that input to the body. Then we give input to the mouth. Okay, this is really interesting. Play is an important childhood need, so fundamental it is enshrined in United Nations conventions on the rights of the child. Did anybody know this?
No.
So we know the barriers to play are multifactorial, all right? We live in that culture that protects now and directs children. Very different from the way we were all raised. There are school expectations. A lot of parents talk about the hours their children are spending in homework at night, okay, or other school-related activities. There's scheduling demands. I mean, I think parents are coming in with their own planners for each of their children because they have them so booked up in the day, there's no room left to play. And then we have a fear of risk. How many of your schools have swing sets? Anybody? Or the merry-go-rounds? Okay, I see one swing set. Okay, but there's like 40 of you in here, right? There's a risk of lawsuits. So unfortunately now we don't let kids move. We're afraid someone's going to get hurt, someone's going to get blamed. It gets really expensive. There's environmental factors. I live in Los Angeles. You know, lack of green space is definitely an issue. There's parents that are afraid for their kids to walk through high-crime neighborhoods. Even though the research isn't showing that kidnappings and some of these things are up, we think it is because it's so much more on our radar because we have access to social media and everything gets posted. And parenting styles. Jansen and colleagues found there's 4 types of hyper-parenting styles that impact physical activity of children 7 to 12 years of age. I think we all know what a helicopter parent is. Okay? Yep. There's also now snowplow parents, but that's not relevant to this discussion. Snowplow parents. The little emperor children are the ones that parents come in and just want to give them every material thing they can possibly provide. We have tiger moms. I think you all know what those are.
Explain.
Okay, so tiger moms have this need for their children to succeed. A lot of times it could be related to academics, very aggressive in that area. And the parents that are more concerted cultivation are those that are looking to get their kids into Harvard and Stanford. So everything has to be an enrichment experience. So they're booking their kids' schedules up on that behalf. And what they found was that with the exception of helicopter parents, hyper-parenting was associated with significantly lower physical activity. Which leads us to some playtime pearls. Okay, so everybody put your pearls on or count how many pearls you get out of this from here on. So an intake pearl that may help you understand a little more about parenting styles that could be barriers to your children's play on your caseload. Observe parents in the clinic. You know, you're all looking at their posture, you're listening to their speech and the things they're doing, or they're sitting in your waiting rooms. You can glean a lot from what parents do in a waiting room. And you can also ask them, you know, parenting style questions in your intakes to get that bigger picture. Ask it in a few sentences, or give them a checklist that's just really simple. No judgment, you're just collecting data. Really consider that for parents and professionals, parents are a child's first teacher. Okay, I think everyone in here who's a parent can relate to that. We follow a child's lead, which is what's so beautiful about play. They're invested in something that's meaningful to them. They're attentive to it already. And play gives meaning. Okay, the brain is always neurologically searching for meaning. It's searching for connections, and play helps to provide that. And play, you know, when we're thinking about play, we want to stay within the zones of proximal development, which is not going too far beyond a child's level and where they're just feeling frustrated and they give up. And we're not going too far underneath where they're just bored and say, I'm shut down. It's like you're on a ladder and you're just bringing them right up to your level. So we want to consider that movement is essential both indoor and out. Okay, Dr. Robbins and I really feel like it's important as therapists, as dentists, as anybody dealing with the body to consider lifestyle plans that people move in and experience the world in. That sitting, standing, supine. We know standing increases executive function skills and working memories. You guys can look up research on standing desks that they've decided to use in workplaces and some of the schools. And play incorporates all the senses. And when we incorporate all the senses, we're promoting good cranial nerve integration. So we can help parents take the pressure off, hey, just go home and play with your child, right? There's some 5 easy steps. Allow them to start this in a doable time frame. Maybe it's just something they add into their day for 15 minutes, right? Not too much time. If it's a hit, they're gonna keep going. Most kids love it, parents see the benefit. Pretty soon you're well beyond 15 minutes a day. Find ways to incorporate play within daily routines. I mean, parents don't want to feel like therapists, right? You can do it in bath time. You could do it at mealtime while they're helping you cook in the kitchen. And gosh, all those old sensory experiences through cooking and play. Helping designate a safe outdoor place for play. Then parents aren't as worried, right? Everybody can feel good. We want children to be the directors of their own play, kind of like these kids down here. And you can see that play doesn't take much. How many of you had kids who loved the Tupperware and plastic spoons and boxes? I used to run mine up and down the hardwood floors, and we'd have like pretend keys, and it would be their cars, and we'd make all kinds of sounds, and we'd go places. So play is imaginary. Remember that slide with those 20-some different words about types of play? Okay? What really happens when kids dress up? Why is play important? It allows us to role play, okay? That's endless opportunities to utilize the craniofacial respiratory complex when we role play. We articulate a wide range of sounds when we're role playing. We speak in different volumes and tones, which is going to have different requirements of the airway, okay? Kids communicate feelings, and they're activating facial muscles that are crucial for nasal breathing. Okay, and we can create settings like tea parties, dining out, grocery shopping. You can utilize real foods. Now all of a sudden they're having that sensory experience with food. They're having opportunities to chew and to swallow. And it's fun. And guess what? They want to keep doing it. So some of the things we do, we don't have much time, we're not going to explain all this, but to work on oral resting postures indoors, it might be during hide and seek activities, scavenger hunts, playing board games, building. Beach ball walk is something we do, balloon taps, arts and crafts, moving to outdoors. You can see the list over there. Okay, there's a lot of ways to work on oral resting posture that's fun and that's playful. We can look at overall body posture and work on that through swinging and Superman swings that helps activate the core muscles. Again, connecting back to the slides you saw earlier. Bouncing on medicine balls also activates core muscles. Horseback riding, climbing, using trampolines. This is all play. How many of you are going to go out and play sometime today after this lecture?
Oh, yeah.
Maybe tonight.
Wait. Guess what?
Would you all like a little play right now?
It's time to play, guys. Everybody up.
Okay.
Okay, so last night we were at a board meeting, and Mark wanted Nicole and I to wear cowboy hats while we were talking for our lecture. So we were out last night at one of those amazing, on the strip, one of those,
3-story.
yeah, 3-story.
Music, guitars, honky tonk row. Yeah.
And I'm like, you know what? Let's do the Tennessee hat dance. Okay, so this is just getting creative with play and how you can come up with things to do with your patients when there's low function. So Nicole,
Oh, sorry.
let's do the Tennessee hat dance, okay? Everybody take their hands.
Get your hat. You all got your hat in your hand. Put it on your head.
Tip.
See it?
And here you go. Yee!
Oh.
Right? So we got the E and the ah. It's just an idea of how to come up with things for your patients. So one more time and get ready for the gala tonight. So we'll all do the Tennessee hat dance. Ready? Tip your hat. Yee!
All right, this is going to be the quickest case study you've ever seen. But you all just played and you moved and you got your brains working, so you're ready, right? Yeehaw, here we go.
Okay. So, when we're looking at our patients, one of the most important things that we need to do is take the detailed medical history. You want to get they fill out the form, but they don't always tell you the whole story. And you have to kind of dig a little bit, or a lot of it, to get the information. So really, the mystery is in the history. Right, so this is Luna. She's 2 years old. She presented as a patient for me for routine dental care. And so in terms of the medical history, she had a lingual frenectomy between 3 and 5 days old at her pediatrician's office with scissors. And she also had an undiagnosed labial frenum. She had no difficulties latching, no reports of gas, reflux, colic, frequent fees, sleeping at the breast, weight loss, maternal nipple pain, mastitis, engorgement. There were some hiccups after the first 6 months, and the mother did supplement with breast milk in the bottle. In terms of her posture and feeding, she had torticollis, which she had 1 month of occupational therapy and physical therapy, and she was unable to breastfeed on the left side. She breastfed for 2 years. All right, so there were no drug allergies. She was allegedly eating varied solids. So what parents may think are solids or hard foods are not necessarily hard foods. Right? She's brushing 0 to 1 time a day, so probably not at all. She crawled at 8 months, walked. She has a difficult time falling asleep. She falls asleep on her back, stomach, and right side, and there were no reports of snoring. She had some sensory issues to loud sounds and noises, and she was on the pacifier, but she stopped just before she came to the dental office. Right, so on her exam, she had a convex to straight profile. There was a twist and a bend in the right side of the neck. Remember the x-ray I showed, okay? She rests her tongue between her teeth and her lips are apart at rest, and she has string to close her mouth. In terms of the soft tissue, she had a diastema between the 2 front teeth. She had a modified no 4. Couldn't see the tonsil. She had a high arch palate, and she was tongue-tied. In terms of her bite, her bite was still developing. Her second molars were still coming in. And as it was forming, she was starting to develop a bilateral crossbite, right? And she was starting to have cavities on the front teeth. And what we've seen is that kids who have the high labial frenum, the milk will pool around the teeth. They can't clean it, and then they will start to get cavities. Okay, so she's starting to do that. In terms of, these were the treatment recommendations. But I felt, looking at the history, that she was not ready for a release yet. She had already had occupational therapy and physical therapy, so I felt that the best thing for her would be to refer her to the speech-language pathologist and a myofunctional therapist, and also for some neurointegration. Okay, so from the time I made the recommendation to the time they actually went to do it took 3 years. So it's every time coming in for their preventive checks and planting the seed and cultivating the seed and educating. It took a long time. Finally got her to go to ENT because she was starting to develop sleep problems and now all these different issues. So I really want to emphasize that it doesn't happen overnight. It can take a long time for them to get to where they need to go. Now, and also, they came to me as a dental patient. They did not come to me as an airway patient. So the referral source is also important to note. So if they're already coming in with awareness, it's going to be a lot easier.
So when Lena came to me, there were concerns regarding her speech, tongue placement, and oral-facial growth. Dr. Robbins just gave you a great description of what was going on. Some of the concerns from my end were that as a preschooler, people couldn't understand her. And one of the bigger things that struck me as a speech and language pathologist is this might have been a kid with selective mutism. So when you think of like that tongue tie and when to release, if this is a child that's not going into school, that's not going into environments with strangers and being willing to talk, she's not going to be moving her tongue that often. And it also tells you how much she is in her limbic system, which is, in my eyes, and I think Dr. Hila's, is not a great place to go release, a great time and space to release tongue ties.
You have to consider the whole person. Again, the mystery is in the history.
So family history-wise, I'm wondering, is this slide helpful for me to go through, given that you've already got me other stuff? Do you guys want me to spend much time on this? I can just skip along. I just want to make sure we have time.
So I have a question real quick.
Yes.
So did you decide she had selective mutism? You personally
No,
decided
that's a good question. No, I felt like it was a matter of ongoing diagnostics. Just because that wouldn't be something I would diagnose by myself. I think that comes from an interdisciplinary team, but it was on my radar that there was a piece to her presentation that looked like something like that.
That's a good question.
Yes?
That's a term I haven't heard before. Like when you go to
Selective mutism is when basically you'll see children that may be talking more at home with familiar people, and they get into social settings, school, and they will whisper, they will use hand gestures, and there's different reasons for this, and it's interdisciplinary because there's also some like psychological pieces and other things.
Thank you.
You could have kids with trauma. So temperament-wise, she had a quiet personality. From a speech and language standpoint, she was 75% intelligible with caregivers, 50% with unfamiliar people, and those are people she would be willing to talk with. Utterance-wise, she had 5-word utterances. Thank you. Okay. So on her evaluation, Dr. Robbins already mentioned she was using a pacifier. In terms of resting posture, she'd been in an open mouth posture the majority of the time for the first 3.5 years of life. Okay, sometimes in the day and at night. Her tongue was low and forward at rest. Sometimes it was interdentalized. Swallowing-wise, her lips were strained and closed to create a seal. She had that overactive mentalis, which you already heard about, and she had recruitment of accessory muscles, which tells us something's going on with cranial nerve 11. Inefficient bolus collection, reduced lingual palatal suction for the bolus transport was evidenced by food residue. She had bolus loss. Okay, and some of the stuff going on with her tongue, I want to point out, was also asymmetrical at this point. Chewing-wise, temporalis and masseter is activated bilaterally. She had reduced lateralization of tongue to the molars for chewing. She tended to chew more in the front of her mouth, which think of her occlusion, think of that twist in the cervical spine. She had an immature chew pattern. She was predominantly a right side chewer when she did get out of the front of her mouth. She had overactive perioral muscles. Oral sensory system-wise, she had reduced awareness and a very active gag. Sorry guys, are we still? Yeah. Good, okay. Anyways. So, she basically getting to recommendations. We started with doing something called the expanded expression tool. So I started looking at how to facilitate the expressive language component, even though they didn't specifically come in for that reason. This child kind of started blossoming. We were doing this speech and myofunctional therapy. We discussed discharge of the bottle, which when she came in for evaluation, she was still using a bottle, and they managed to get rid of that within a week. The functional dentist for orthopedic remodeling with Dr. Hila, the osteopathy for midline issues and posture. Okay, and then just to continue monitoring her airway and
So this is, where she presented before we started the orthopedic remodeling. No. And this is just to show the different postures to look at. This is how she presented, and remember that x-ray I showed you guys. Look at the crossbite. Twist to the right. She's got the right crossbite. Here she is after about a year. How many? It was over a year of orthopedic remodeling, and she had her tongue released. This is the change. You can see we go back.
sorry.
Oh, one more. That's fine. What I want you guys to see is look at the posture change. Okay. Look at the change in the twist of the head. When you look at the initial picture, you can see the ears aren't level, the eyes aren't level, there's an asymmetry to the face. The shoulders are up. One shoulder is higher than the other. Look at the scapulas, how they're scaffolding in. This is how she presented. Look at her gait. See that she's stuck. There's no movement. Look how her head is twisted. Oh, it's not quite that great, but I want you to just look at the arms. Look how she's moving. The whole body's going.
Okay, so, wow. This is just to show you guys some of her posture, her progress by the time we hit March. I think her first measurement on the Markazon protocol was like 42%, if I'm not mistaken. We'll see that on the next slide, and not that we're married to numbers. But we'd already seen some improvements in therapy. And on the Goldman-Fristow, I'm sorry, I don't know where the original slide was back at the beginning, but progress-wise, we were down to 2 errors on a Goldman-Fristow. And I count errors based on placement. So she had a lot in her initial assessment. Moving along. When we started, here's the number. She was at 42%. By the time she had had therapy and help with Dr. Robbins and the lingual and labial releases, she was up to 65%. And I think it's important to just point out the symmetry of what's going on versus before we were seeing lots of asymmetries impacting the functions and the structures. And this is pretty much where she is right now. And hopefully you'll consider this quote from Einstein. We thank you guys all for your time and attention, and we're super happy to talk about it.